Okay, hi everybody. It's lovely to see such a big crowd, and I see we've got some people in VGHER. Hello to you guys. Okay, so basically the backstory for this is that this was came out of a Michael Smith Foundation Health Research call for nursing research proposals, and they were specifically looking for proposals that came from a collaboration between a practice nurse and an academic nurse. Well, I'm the practice nurse, right? I'm a clinical nurse educator. I've been an acute care nurse for 33 years, and but I love research. But as a clinical nurse educator who does not own a Ph.D., I've never had access to research funds, and I thought, this is my perfect opportunity, man. Like, this is perfect. So I emailed my good friend Annette Brown, who's a nurse researcher at UBC, and Bernie Pauly, and said, I've got a really good idea for a research project, and I think we should apply. And so basically, I mean, I've been dealing with people with addictions. I work at St. Paul's Hospital, which probably some of you know is the absolute epicenter of addiction in BC. 30% of the people admitted to St. Paul's at any given time have an addiction issue. And so I have obviously witnessed over the years all kinds of issues with it. And the biggest concern I have is just in terms of the kind of nursing care this population gets, because they're so highly stigmatized. And so I said to Bernie and Annette, I think we should do a project that's framed in the concept of cultural safety to see what the experiences of these patients are and what the perspectives of the nurses are that care for them, and see if we can figure out a better way of doing things. And so we put in an application, and what do you know? We got the money, so which was very exciting, and so yeah, so that was all great. We were very happy. So we put together a big team, and one of the big things we wanted to do was we wanted this to be a very collaborative project, and I also wanted to make sure that the nurses at the hospital had an opportunity to be involved in the research, because of course frontline nurses in general have very little experience or exposure to research. And we know that frontline nurses in general, from all kinds of stuff that people have done and studied, frontline nurses in general don't see how research has any relevance to their working lives in general. They just don't perceive it as having relevance. So I thought this was a really great opportunity to actually expose them to the research process and hopefully give them a better sense of how research actually does impact on their lives. So we created 2 advisory committees. One was a peer advisory committee, and it was comprised of people from SOLID, which probably most of you know is the Society of Living Injection Drug Users in Victoria. So we had some number of people from SOLID that created were our peer advisory committee, and then we had a nursing advisory committee. That turned out to be a bit more complicated because we initially started out with a core group of nurses, but because of their shift work, we could never get them all in a room at the same time. It became quite challenging. So we sort of morphed it, and the nursing advisory committee actually ended up being whoever the hell was working that day. So, we'd go into the hospital and we'd have some findings. We wanted to find out what they thought of the interview guide, or we had some findings to report. We just sort of collect together whatever nurses were around, and they became the advisory committee, which actually worked well because it meant that we actually exposed a whole pile more nurses to the whole research process. So it actually worked out well. So, as you guys know, drug use is highly stigmatized in our society. It's highly criminalized, which is part of the problem. And what we know, of course, is that stigma disproportionately impacts people who are socially disadvantaged. There's lots of rich people in this world that use cocaine. They're not particularly stigmatized, right? They go out for the weekend, they have a good time, they snort a few lines, they go back to their jobs. They're not particularly stigmatized people. The people that are really highly stigmatized are the people that are already socially disadvantaged, people who are poor, people who are insecurely housed. Those are the people who really bear the burden of stigma around substance use. And there's, of course, a web of stigmatization. And we know that there's multiple and intersecting stigmas that really impact on people, right? I mean, they have the stigma of HIV and hepatitis C. They have the stigma of their ethnicity. There's all kinds of other stigmas that kind of impact on this population. And of course, stigma is an evolving conception. I mean, Goffman originally came out with this, called it the spoiled identity. And then what's come out since then is we've come to understand that stigma is really about power relations, right? So some groups have the power to name or label and stereotype another group. So stigma clearly is not just about the labeling, it's also about the power relations. And stigma has negative impacts. It has negative impacts on health. People have low self-worth, they're stressed, they're socially isolated, they're excluded. All of those things, clear research shows, has significant impacts on people's health status. It has impacts on people's access to health care. People who are stigmatized are very reluctant to access health care because they're fearful of how they'll be treated. And of course, care providers have very negative attitudes, and there's like a multitude of research that demonstrates the negative attitudes that care providers have towards people who use drugs. So, there's a lot of gaps. So we have a very limited understanding of what is perceived as safe and appropriate health care from the perspective of people who use drugs. And there's a lack of knowledge of the ways that our nurses and other healthcare providers can mitigate barriers to healthcare experiences for people who use drugs. And we need a better understanding of the factors that facilitate or impede enactment of safe, competent nursing care for people who use drugs. So what do we want to know? These are the questions. What is culturally safe nursing care in acute care settings for people who use illicit drugs and face multiple social disadvantages? What are the similarities or differences in how people who use drugs and nurses view culturally safe nursing care? And what are the necessary elements of practice environments that promote culturally safe nursing care? So, of course, then you get into the whole thing, well, what does culture mean anyways? Well, traditionally, nurses have treated culture as synonymous with ethnicity, but we've come to understand that that's actually not a very good idea, because what happens when you do that is you run the risk of stereotyping people based on their ethnicity. You say, oh, well, he's a Chinese person, so we know his, this is an old Chinese lady, so we know her family will look after her. That's very much cultural stereotyping, right? Because you basically are making assumptions about the kinds of things those people do based on their ethnicity. So an expanded view of culture basically positions you to understand it's a relational process. It's actually embedded within a shifting set of meanings that are related to historical, social, economic, and political processes. And it's not reducible to an identifiable set of characteristics, and it's not politically neutral. So culturally safe care actually comes out of that sort of expanded view of culture. That's where it started from. And culturally safe care was a framework that was developed in New Zealand because in response to the needs of Maori people, because what they understood, Maori people are very marginalized and stigmatized in New Zealand, and Maori people have great difficulty accessing the healthcare system. And they're often treated in a very culturally inappropriate and insensitive way. So culturally safety was a model that they created down there to try and deal with that issue. And basically what cultural safety is about, it's about recognizing one's own privilege and the positioning of certain groups within a society. It's predicated on understanding that there are power differentials in healthcare service delivery. I don't care how powerless nurses think they are, but in fact, in the context of the healthcare system, nurses hold a significant amount of power. In relation to our patients, we have the power, right? We may feel powerless in the grand scheme of things, but we actually do hold a lot of power, and I think it's really important for us to remember that, right? And so the goal in cultural safety is to counter the tendencies in healthcare that create cultural risk or feelings of feeling unsafe for patients, okay? So basically, in terms of what you have to do, it's about analyzing your cultural self and positioning. What do I bring to this relationship? How much power do I have in relation to this relationship? Recognizing power imbalances exist. Recognizing that we all operate from stereotypes and assumptions. It's just natural human behavior to do that. And it's okay as long as you know what they are, right? And basically, cultural safety can be used to operationalize equity and social justice. So where this sort of started from was that the RNs working at Insight several years ago recognized that cultural safety was a very useful approach for working with people who use illicit drugs. And they started to enact it within their facility. Okay, and now it's Bernie.
So I think you can see the ideas for the research came from practice, and it was really the big aha when we were working with the nurses at Insight who were trying to articulate their practice. They had taken up cultural safety because they cared for a lot of people who identified as Aboriginal. And then they said, but this seems to work with everyone. So it's kind of interesting about this is we took an Indigenous developed concept to see how it applies more broadly, and I don't think we had that quite as explicit at the beginning as we do now. Jane already mentioned, so what I'm going to do is tell you a little bit about the research and the findings. Jane already mentioned that we had the peer advisory and the nurse advisory because we were working with an overall collaborative, community-based approach to research. And as she described to you, the nurse advisory was kind of pieced together, and it was whoever was on the unit at the time. And I just want to tell you the flip of the peer advisory was a very consistent group of the same people through the 2.5 years of the study. And so these were people who are, many of them may have past or current experience with illicit drug use. Many of them had very, their housing could have been unstable. And so they were people who had experience of the topic that we were working with. And I remember particularly one person who was part of our advisory from the beginning, is he said, I don't always remember exactly what this project is about, but I know it's really important. And so he really, their group really kept us grounded, because what we did with both groups is we went to them with our research questions, our interview guides, our beginning analysis, and that's what this is laying out. So we started out, we did our nurse interviews to find out their perceptions, and then we did an analysis. We went to both the advisories, we met with them, then we did our patient interviews, we went to the advisory. And at the end, one of the things we did is we brought them all together in the room. And I recall really clearly someone who he wasn't on the peer advisory, but he was from a member of a drug user group who said, this is a conversation that's long overdue. So what it meant is the nurses and people who identify as using drugs were actually having the conversation together about how do we improve care. And so we'll talk about it in a bit, but we produced a little green kind of CAR-BC bulletin with the support of CAR-BC that was jointly produced by those two groups. That was one of the products. So you can see this was kind of our process. It was a qualitative ethnographic design, and we used interpretive description to analyze the data. Because it was ethnographic, we did participant observation. Now, Jane and all the nurses, they live and breathe the setting. But myself and Joanne, who was a research manager, I'm a nurse, Joanne was not, but obviously I'm familiar with nursing practice, but we did about 275 hours of observation on the units where the study was conducted, which was a little bit challenging because I was going back and forth between Vancouver and Victoria to do that. But we also did our interviews with nurses and patients, and then we brought in documents, and we identified through the research particular documents like the hospital substance use policy that were important to look at. So here's kind of quickly a snapshot of the interview. The people we interviewed, we had 50 patients, 8 men, 6 women. We worked really hard to connect with the women, and many of the women did not want to speak to us about substance use. And that was definitely consistent, as you know, with probably your own experience and the literature. All of them identified as using illicit drugs in the past 12 months, and 7 of them identified as Aboriginal, and they all met that criteria of being some type of social disadvantage, unemployment, living on social assistance, and either homeless or unstably housed. And then the nurses, we had a combination of frontline and nurse leaders, wide range of experience, 4 to 33 years. Most of them were educated with a degree, 2 with a master's degree, but almost all of them had not received any substance use specific education, because remember, these were medical units. They weren't specialized addiction settings. Now, Jane had the brilliance that, she said nurses don't often get to see research, so we always kind of include this. After we did those interviews, we all read them, and then we came together and we did this initial concept mapping to start to lay out what can we say about culturally safe practice with people who use drugs. And so that was just a snapshot of our first messy analysis. Researchers often don't show you this, and so I wouldn't have even thought of showing you this, but Jane always reminds us that that's a good way to do it. In fact, you've done a whole presentation on the process of doing the research itself. So what did we learn? Well, we learned a lot about how patients and nurses view substance use, what they think about culturally safe nursing care, and factors in the environment. And I have a little star by that first one, patients and nurses' views on substance use. You will note that actually wasn't one of our research questions, but we did ask people about about substance use in hospital. And it's really quite important because if you think back to all those things Jane said about cultural safety is a lot about reflecting on stereotypes, how your position of privilege. So getting this view of how substance use was understood was really actually very useful, and we had a huge amount of data about it. And that's very typical of qualitative research. So now I'm just going to briefly share with you some of our findings. The findings that I'm sharing with you are spread across 4 publications. So I'm trying to bring you a snapshot of those because you always have to kind of parse it down, right? And we can certainly, we've got some of the CARBC bulletins here, but we can certainly share with you some of the other ones. So this was kind of the first piece that we really looked at in the findings, how substance use was taken up and understood in a hospital setting. And it's largely a very kind of stigmatized stereotype production of substance use. And in this case, what we should say, remember this was focused on illicit substance use, so not necessarily alcohol. And we had to kind of make that distinction early on because we wanted to look at the context in relation to drugs that were illegal. So what you have is illicit substance use being very individualized, very criminalized, and very medicalized. And what, in terms of the individualization of the way people saw it, they saw people as something they brought on themselves, that it was their fault, that they just were not being responsible. But sort of, so patients often felt very judged as an addict. And I guess in a way, I mean, I did my dissertation and for my Ph.D. in 2005. This doesn't sound any different. People describe feeling like, I mean, the findings were almost the same. I felt like I was living kind of the same research at times. But what was really interesting was the nurses. While some of them took up this kind of individualized blame kind of focus, some of them said, I actually don't think that's the way it is. I think there's a set of circumstances that make it that produce this problem of substance use and addiction. And so they had just a bit different view around that. People felt very criminalized. They felt like they were under surveillance all the time. Some people described the hospital as a prison among the patients. But both the patients and nurses talked about how they worked to resist criminalization. So just think for a moment, and Jane and I just had this conversation, Forte, what if we did this again and we were under a very different federal government? Right? It blows my mind that we're talking about this 4 days or 5 days after we have someone, a significant shift at the federal level, and I'm gonna make some implications about that later. And then lastly, it being very medicalized as the disease of addiction and not seen as a public health problem. So it's not seen as the problem of HIV or the problem of hepatitis C, but it's seen as a disease of addiction that we have to treat. So in terms of, I'll just give you a few examples of each of those. So this is from patients. Here's some quotes. I've seen the way they treat people when they've had drugs. You're a drug addict. You're considered a drug addict. It's a label. And so really this person is emphasizing that label of the drug addict. And the part that's really important is they just discard you. And we had a lot of people saying that they felt like garbage, that they were just being discarded because of that. And that they're always opinionated. They had an opinion on what you're doing to yourself. And so they didn't like to be there. The hospital is not a safe place for people to be. Here's the nurses, sort of bringing out, the person has made poor choices. They make poor choices. So, we just need to let go and not be so focused on getting them better. But here's the quote I was talking about, where the nurse on the bottom is one of several nurses who talked about, we just have to remind ourselves, people don't choose to end up like this. This is not ideal, to have no teeth, festering wounds, and be covered in bed bugs. It must be really horrible to live like that. So she's thinking about the social circumstances and is giving a very dramatic example. Here's our second sort of a way that substance use is taken up in the hospital, this idea that people are criminalized. They feel very under surveillance. Participants told us about, they were always being suspected of drug misuse. They were worried about asking for pain medication because they feared they'd be labeled drug seeking, and I see some of you nodding because we've all lived and experienced this. And if anything went wrong on the unit, they were the ones that were going to be likely targeted as if there was a theft, well, they were the ones. And we actually had, this is where doing participant observation is very powerful. We actually observed times where, in one example, some patient's room got searched multiple times because the property of another person had gone missing, and it was a small item. I can't remember what it was, but they came in 3 times, and finally the third time, because it was in the middle of an interview, and finally in the third time, he sort of said, I doubt they would have searched my room 3 times if they didn't think I was a drug user, but I'm the one. And so the upshot of that is that people are not going to trust the healthcare providers. They feel like they have to have this game face on. They're very hesitant to ask pain medication. Of course, they're going to leave against medical advice and not continue. And some of them, though, had very elaborate strategies about how to create themselves as a credible patient, how to distance themselves. There's sort of good drug users, bad drug users, and they were a good drug user. And how did they position themselves? Who did they align with? So they had some really interesting strategies, and I didn't make too much of that until we sat down with Solid and talked through the findings, and they said, oh yeah, that's totally the way that you can try to navigate so that you can get good care, because their big worry is they wouldn't get good care. Interestingly, I said to the nurses when we did the preliminary findings, I said, we're hearing all this about criminalization. And we had a little bit of, we didn't have the nurses talking about criminalization at all, except for this kind of one quote, which I thought was really super insightful, where she's saying the harm comes from prohibition and the harm comes from the law. And you can see she's saying it's the illegal nature of the drugs. And so when I said this to the nurse advisory, they all looked back at me and they were silent and they had this really puzzled look on their face. And I remember one nurse saying, I don't know how I could provide care for people if I thought of them as criminals. So even though they weren't articulating it, they hadn't really been thinking about it, this, regardless, is still the milieu that they are have to practice in or are practicing in. Medicalization, substance use as a disease. Patients said, I still know my body. I still have information about how I want to be cared for and treated. That was the top 2 quotes, and then the bottom quotes is a nurse who's putting forward that this is just a disease process. And what this leaves out is all of the public health approaches for preventing HIV, for preventing hepatitis C, because it's not being seen as it's also a public health problem. And so we want to deal with that in hospital. So for people who use drugs, the hospital is highly stigmatized and safe. It's deeply embedded in our systems. It's reinforced by current drug policy. But cultural safety draws our attention to what is needed to create safer environments. And I'll just give you kind of a quick insight into what is culturally safe care. So from the perspective of the patients, it was really important to them that they were seen as a person, that they had space, that they weren't written off, their concerns were taken seriously, that people trust them, believe them, listen to them. Examples of that were where nurses would actually sort of take the time, and it doesn't take a lot of time, but just to listen to what their requests were, what their needs were, to ask them. This is so basic to nursing. We're not asking about anything. It's so basic, but it's missing. That's the point, right? You know all of this. I don't need to tell you this. You know, and we had some great little examples where people said, you know, if they come in and they fluff up your pillow and, you know, they tell you where the water is and you're allowed to actually go and use it, those are such little things, but they are so not little things. They are huge because they symbolize your care and respect for someone as a person. Not coming in and not rushing and hurrying. They know that nurses are really busy, but they also said, you know, the nurses who came in just kind of came in, were calm. I remember one nurse that I observed, she was brilliant. She knew her patients so well that she just organized the day, so she gave all of their care in a very discrete block of time so that they had time and space outside of that and didn't feel like they were under surveillance all the time. Explanations, can't say enough about that. Tell people what you're doing and why you're doing it, just like you do with everybody. From nurses had great insights about cultural safety, how you shift it. I mean, these again are things that I think many of us know, that it's not about you. When someone is yelling and screaming, it's not about you, but recognizing that they're really struggling. That's the quote on the left. So just getting kind of that thick skin. And then on the right, recognizing trauma, power imbalances, the fact that people aren't coming in with a level of trust. My husband was just in the hospital 2 weeks ago. He broke his hip. He got great care, I have to tell you, in Island Health. But, you know, we came in, we believed and trusted that we were going to be treated well. And I have to tell you, I used all the tools I had at my disposal. I told him I was a nurse. I told him my husband was a pharmacist, right? That wasn't just a one-off. That was planned, right? So, you know, I came in, because we had a long conversation. My husband works in an inner city pharmacy, so, you know, we had a long conversation about this. But I think one of the things that was so profound from the nurses, they said they had to rethink their goals and expectations from fixing or curing or dealing with people's addiction to the primary thing being about building trust and starting that trusting relationship with the implication that then care could be completed. And this is a wonderful quote from one of those nurses about planting a seed of safety. So the whole thing that motivates me is maybe to plant a seed of safety, trust, because a large proportion of our patients, they have a really hard time trusting people. It's really hard for them to access any kind of treatment or services, so I try really hard, you know, to establish some kind of safety. And I don't really think our patients need any more people judging her. So culturally safe care was about starting to develop those feelings of trust. And I remember her very vividly because one of the things she did, people would go out if they were able to go out for a few hours, and if they didn't come back, they were technically supposed to give the bed away. But the nurses were really great at holding the bed as long as they possibly could because they knew their patients well. And I remember this one guy came back and instead of saying like, I held that bed for you, she said, wow, you came back, I'm so glad to see you. It was just such a reversal. So what supports culturally safe care? This organization has a clear commitment to serving people who use drugs. They were committed, all of the nurses told us that harm reduction was the organizational philosophy, values. They talked about medical teams that were resourceful, the addictions team in the organization, and if they had opportunities for education. What made it harder? So obviously they have to work in a milieu of very negative and stigmatizing attitudes. There's not a ton of opportunities for education. There's a lot of resource constraints, so there are judgments of who's deserving, who's not. And it's really hard to establish a culture of working with people who use illicit drugs when you have a lot of high staff turnover and when you're dealing with a lot of different kinds of patients from, elderly people and so on, and how that mix. One of the biggest things that was identified, all the nurses kept saying, it's harm reduction that helps us really deliver care in this way. And at one point, Jane, I remember being in a meeting and I kept saying this, and I was like, because this was not a study about, and Jane said, this is not a study about harm reduction. And I said, I know it's not. It's a study about culturally safe nursing care, but what they're telling us is that being able to have a harm reduction philosophy is what helps them to enact culturally safe care. And so then we'd ask them questions like, well, what's your policy on that? Or what, our first question was, what would you do if you came into a room and someone was injecting? And people said they'd walk away, they'd pretend they didn't see it, that they wouldn't know what to do, they might talk about their colleagues, but, and we said, well, what does your policy say? And they said, well, we have a policy. Well, where is that policy? I don't know. I said, okay, and I sent Jane off, and I said, this is so great when you have practice partners, because you're like, Jane, can you find that policy? I don't know how many hours Jane spent looking for that policy. She could not find it. And Jane is very knowledgeable. So the nurses believed that harm reduction was official organizational policies, but there were actually no policies around that, and even more so, the substance use policy as currently written in the organization did not embrace, it embraced abstinence, not harm reduction, as the policy. And as well, even if they took up the abstinence, this was a side note, they said to us that there weren't, even if I sort of embraced abstinence and a client wanted abstinence, they didn't have good access to withdrawal and treatment services to refer them to, so they were kind of in a double kind of bind. So a big issue that came up out of the research was there were very unclear harm reduction, substance use and harm reduction policies. Nurses believed and enacted through respectful engagement principles of harm reduction, but their policies actually said zero tolerance for substance use and no harm reduction policy was found. So this is, so here we are. How did nurses handle this then? A lot of what was going on is what we've come to call blind eye harm reduction, where people turn a blind eye to substance use that's going on. And so they're putting themselves and others actually in an unsafe situation because they're missing opportunities to promote health and well-being by not being able to provide appropriate harm reduction services and education. So you can kind of imagine, I'm the researcher. I was very fortunate to have a practice partner who was okay with hearing what I would call kind of not good news, right, about what was going on. But we always, through it, we always talked about the good news. We talked about the good news, and here's the not so good news. So what did we do with all this? We had the policy forum in Vancouver that I talked about. We actually had some lunch and learns here. Island Health was extremely supportive. The cultural safety program, and I don't know if there's anyone here today, but they were very supportive of us putting out our research. And so obviously we've done a huge number of presentations and findings, but those policy forums were really important because they helped us to craft the recommendations that went into this little CAR-BC bulletin. So what we did is we did a presentation, much like I just gave you, and then the second part of the policy forums was a workshop. Well, sorry, we had people from Solid, nurses, comment on their perspective on the findings, and then together we worked to develop the recommendations for culturally safe care, which we have some of the bulletins here, but I should say it's also available online. So what does this study add? Well, reinforces healthcare environments are highly stigmatized. Trust has to be earned and is a key priority in culturally safe nursing care. Harm reduction and trauma-informed care are part of culturally safe nursing care and creating culturally safe environments. Policies matter. We have a very conflicting set of policies up until Monday. We had a very conflicting set of policies. We had federal policies that were anti-harm reduction and abstinence-based. We have BC provincial policy, which is the most favorable in the country. Harm reduction is official BC policy, and I'm not just saying that. That comes from people at the ministry that say that. So organizations are all over the place with their policy. So I'm excited to think, how will this change? We have a PM who says, I'm going to support supervised injection, who's interested in legalizing marijuana. That's a very different big policy environment. So how that will play out, because I think what's always happened in our conversations is nurses haven't been able to deal really with the issue that the federal government has taken a certain position on illegal drugs. But what we always have said is our professional and ethical standards of practice are aligned with using the best evidence possible, and so therefore harm reduction is good nursing practice. And so we've always, and Jane and I have worked on multiple things around this, so we need it. So we've argued in healthcare organizations we need policy that's consistent with our practices of ethical standard. And then I already mentioned the public health piece. So the story continues, and Jane's going to finish the story with a very happy development.
So this is great. So of course we have these findings, and you know it comes to the attention of my program leader of the Urban Health and HIV program and my ops leader that nurses are in a pickle, right? On the one hand, we have the Canadian Nurses Association and the College of Registered Nurses of British Columbia saying nurses should be providing harm reduction to patients. That is a practice expectation. And on the other hand, you have this hospital saying, no, you can't do that, which means nurses are actually not able to attain their standard of practice. So we said we have to fix this. So we sat down and we pulled the two policies, the philosophy of care policy and the substance use policy. Now I have to understand the philosophy of care policy originally said that abstinence was the only expectation, that when patients come into hospital that are using substances, abstinence is our only direction of care, okay? And the substance use policy said no drugs ever anywhere, basically, in a nutshell. So we rewrote them. And the philosophy of care policy now basically says in a nutshell, I mean it's quite two and a half pages long, but in a nutshell says abstinence is still our goal, which makes sense, right? These are sick people. We would prefer that they're abstinent when they're in hospital. Abstinence is our goal, but we understand that it's not possible for all patients to attain abstinence in hospital, and we will support them. And our substance use policy now says nurses will provide clean injection supplies to patients who are actively using. Okay, so this is a huge change, obviously. This is a big change. If you guys want to do this in VHA, I will be very happy to send you our policies so that you can look at them and take them up and do whatever you want to do. I am so thrilled that this has happened. This is something I have been working towards for a number of years, so I am so excited. And so basically, that is the happy development. And yeah, I think I'm very, very confident that this will spread, and there are other. Vancouver Coastal's already asked for a copy of our policies. Edmonton's asked for a copy of our policies. So I'm hoping that this is going to spread across the country, around the world. I'm going to a conference in Chicago next week. It's the Association of Nurses in Aged Care, and I'm presenting about our research project and the evolution of policy at St. Paul's Hospital. So maybe the United States will take it up. Who knows? It's a very exciting prospect. So back to the whole cultural safety thing. How is cultural safety, how do we perceive cultural safety being enacted in terms of this patient population? Well, obviously it's about engaging in a process of self-examination. What are my assumptions about this group of people? And what are my views about this group of people? We all have assumptions, we all have views, we all have values that we bring to our patients and the patients, the care we provide for patients, and that's okay. And it doesn't even matter if our values are in contravention of theirs. My value personally is that I would like to see people be absent from drugs because, you know, it's a very unhealthy practice. That's my value. But that doesn't mean it has to impair in the way I care for my patients. I can separate that away from that. But it's about having that awareness, because that's the way you make sure that the care you provide is going to be appropriate and you can develop a trusting relationship. It's about developing an inequalities imagination. It's about taking a questioning attitude towards inequality and disadvantage. Look at your patients. Ask yourself, what's going on with this patient? In what way is this patient disadvantaged? In what way is this patient unequal to me, right? And it's about providing care that's regardful of differences, not regardless of differences. Lots of nurses talk about, oh, I look after all my patients the same way, right? But that's actually not the way of looking at it. It's actually about being aware that there are differences and acknowledging those differences, incorporating those differences into the care you provide. And it's about developing a ritual of encounter, about positively expressing caring, understanding cultural practices, understanding the patient's background, and being purposeful in your relationship building, okay? And I think that's a really important thing. When I think about harm reduction, in my personal opinion, there's a lot of pieces to harm reduction. It's about needle exchange, it's about safe injection sites, it's about methadone. There's a whole pile of pieces to harm reduction, but in my personal opinion, the most important most important piece of harm reduction is developing a therapeutic relationship. Because if you don't do that, nothing else matters. And so it's about providing a safe space for patients to communicate their needs and preferences, being alert to subtle forms of communication that have the potential to marginalize patients, remembering that nonverbal behaviors are particularly challenging. So when the patients talk about nurses who rush in and out, as opposed to nurses who take a few minutes to actually stop and talk and have a connected conversation, that's important, right? Routinely asking yourself if the situation your patient finds themselves in can be considered as safe from their perspective. So when you're looking at your patients, ask yourself, does this patient look like they're safe? Are they presenting as if they feel safe?